this, we're taking 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 with a pinch of salt.
Ladies and gentlemen, dear ERA community, welcome to another episode of A Pinch of Salt, a new podcast series by the ERA. My name is Andres Cobernet, and I'm your host for this podcast. We have a special treat for you. In this podcast, we will be discussing a very common and potentially devastating problem for patients with CKD and particularly patients with end-stage kidney disease, and that is sleep disorders. Sleep disorders are not a very common topic in our educational events, and perhaps not even in our routine clinical work, but as you will see here, this is something we should probably change together. Not only are sleep disorders incredibly common in our patients, but they also have a terrible effect on their lives, and which is also important, many of these disorders can now be treated quite successfully with modern therapeutical approaches. We're very lucky to have with us today Mark Unruh, a leading expert in this field. Mark is a professor and chair of the internal medicine department at the University of New Mexico. He has published extensively on sleep disorders in CKD patients. So, Mark, welcome to A Pinch of Salt.
Hey, Andres, thanks for having me.
Yeah, we're very, very happy to have you here. So, to start things off, I would say that one of the major problems with sleep disorders in CKD patients is that the patients themselves are often treated by young doctors who have never experienced a sleep disorder. And like Joni Mitchell says in Big Yellow Taxi, you don't know what you've got till it's gone. So I honestly believe that it is very difficult to comprehend how bad life becomes when you cannot sleep properly or well enough. Just like it is almost impossible to understand what depression is like if you haven't had it yourself. So for the person who has this issue, I think it's safe to say that it is almost always a huge deal. And maybe we should start by explaining the scope of the problem in our patients. So to start with the most basic of all questions, are sleep disorders a problem in patients with kidney disease?
No, thanks, Andres. I would say that sleep disorders are a problem both in the prevalence of the sleep disorders among folks with CKD and end-stage renal disease, as well as the impact of sleep disorders on those people. The evidence for prevalence is largely done by descriptive studies, epidemiologic studies that kind of compare those with chronic kidney disease and those with end-stage renal disease to the general population. What you find is that I'll hit like the three main sleep disorders that you may come across in your practice, whether it's CKD or ESRD. For instance, insomnia, which is a relatively common problem in the general population, can be found in about 40% to 50% of those who have end-stage renal disease, and maybe a third of those with chronic kidney disease. Restless legs, again, something that is observed in the general population, maybe 5 to 10% in a cross section, can be seen in up to a third of patients with end-stage renal disease. Fewer, a little bit less, and actually the prevalence of restless legs approaches the general population among the successfully transplanted population. And then sleep apnea, which is found to be much more common, and in particular severe sleep apnea, much more common among folks with end-stage renal disease and chronic kidney disease compared to the general population. There was work we did, I don't know, 15 years ago or so, that compared the prevalence of severe sleep apnea among patients with end-stage renal disease compared to like an age, sex, and BMI matched group in the general population using a large epidemiologic study, the Sleep Heart Health study. And we found that severe sleep apnea was fourfold more prevalent among those with end-stage renal disease. So the prevalence of sleep apnea may range depending on whether you're looking at more women than men, but it can range up to 20 to 70% among people with end-stage renal disease. Kind of the impact is actually just as important for those who have sleep disorders. They're found to have poor sleep quality, more fatigue during the day. They are more likely to be depressed. They're more likely to, have trouble with daytime functioning. There's also been associations between sleep disorders as well to cardiovascular outcomes and mortality among people with chronic kidney disease and end-stage renal disease. When you talk to patients, that's kind of what they really care about. There was a really interesting study done by Ram Kumar et al. At the University of Utah in preparation for the frequent hemodialysis trials that went on in the US. And they asked people why they would undergo more frequent hemodialysis. And what was striking to me among this prevalent population on dialysis, people endorsed the improvement of sleep and the improvement of fatigue over extending their life up to 3 years. And so you can see from that people really, like you pointed out, they really miss having a good night's sleep. It's also been interesting for the recent kind of work to engage patients in the science that we do. When you bring together patients together with their caregivers and ask them what we should be doing research on, a lot of them will endorse symptoms, in particular sleep quality.
Yeah, I mean, when you add up these percentages, so you mentioned the three main culprits: insomnia, restless leg syndrome, sleep apnea. And if you add all of this together, you'll get that more than 50% or even 70 or 80% of end-stage kidney disease patients have some one of these three, or even two or three. And that sounds insane to me. I mean, how common that is, especially if you think of the impact. I was recently listening to a prog rock band from England called Yes, and their bass player is a legend, Chris Squire, and he died from leukemia. And I listened to an interview made by the guitar player, and he talked to him prior to death, and he said, "Are you in a lot of pain? Is it bad?" And he said, "The pain is not really all that bad. It's bearable. The problem is that I haven't slept in 2 weeks."
Wow.
And you cannot imagine how devastating that is. And he actually died a couple of days after that. So why is this so common in kidney disease patients? What are the factors that really lead to this being, like, maybe possibly in terms of their perspective, their number one problem?
Yeah, I think that it's multifactorial. And, when you look at the studies, there are so many associations between, kind of the things we observe among folks with end-stage renal disease or chronic kidney disease and insomnia, restless legs, and sleep apnea. In particular, I think there are some novel observations that are made in the group of patients that we care for that have been kind of expanded to the rest of the population. So that actually gets me really excited when kind of our community is informing the general population. Just a couple things to highlight is that there was sort of really neat work done around restless legs and the relationship of having a low iron in restless legs. So iron is a key factor in dopamine production. Restless legs is related to issues with the dopaminergic pathways, so that it's thought that if you have someone who's iron deficient and has restless legs, you can use iron. In both in the general population and in the end stage renal disease population, there haven't been super large trials to test that, but it's a clinical observation, I think, that is kind of made in our population and can be observed in the general population. And the other thing, to me, and this is sort of what first, one of the factors that got me interested in sleep was the nocturnal hemodialysis observations of, when you took someone who's on conventional thrice weekly and put them on nocturnal, then their sleep apnea was mitigated. And later in trying to sort that out, it was largely thought to be due to improvements in volume status. And this has been expanded to other disorders that have volume overload, that if you are volume overloaded and supine at night, you're more likely to have obstructive sleep apnea. And theoretically, you can treat that or improve it by reducing the volume overload. So to me, those are sort of novel, exciting things that were observations that can be made in our population and expanded outward. I think that there are for insomnia, there are so many factors that can be related. You have the usual factors that drive insomnia: age, medications, chronic conditions that we see in our patients. In addition, you can have stress and anxiety related to the illness. You can have, among those that have CKD, the unfortunate effect of the diuretics that we give people, having them get up in the middle of the night to urinate. So there are just so many reasons. Among those with restless legs, there have been correlations made between hyperparathyroidism, hypocalcemia, hyperphosphatemia. Um, again, with the relationship with iron deficiency and anemia. I think in general, one thing I like to note is that for people that are on chronic chemo in center, uh, they're actually being stress tested every time they do dialysis. One of the tests for restless legs is called a sits test, where they have you sit in a chair for an hour, and we do that times 4 every other day, right? So I think, just having people in that position and unable to move is going to be something that provokes restless leg syndrome. And then with sleep apnea, I think it's likely a combination of the chronic conditions, obesity, and volume overload that leads to the really high rate of sleep apnea that we see in our patients.
Yeah, you have already mentioned uremia also as a factor. You mentioned that transplanted patients have less of these sleep disorders, which is again a nice thing about transplantation. And recently we had a patient in our dialysis unit who was a PD patient but became uremic because the technique wasn't doing well, and his sleep disorder was crazy.
Hmm.
Like he was tested and had central apnea, probably because
Yeah, yeah, yeah.
and then he had terrible restless leg syndrome. Like on the questionnaire was 40 out of 40 points, like extreme. So
Yeah.
literally he was awake for 20 hours, then he kind of passed out for an hour, and then he
Wow.
woke up semi-conscious for another couple of hours. It's just not a life that one could live. And when
Right.
we put it on dialysis, it just went not completely away, but to a large degree. So probably it's useful to think about what we can do better in dialysis when we have a dialysis patient. Do you have the same experiences?
Yeah, no, I mean, to me, it's like one of the chronic or the classic observations related to uremia is sleep disturbance. I
Mhm.
think for me, there is mixed data when it comes to kind of dialysis interventions in sleep. For example, the hemo study, the test of dialysis dose and flux, was really no signal when it was related to sleep quality. Among the study looking at frequent dialysis, there wasn't a huge signal, although there was some improvement in fatigue. When you look at um, restless legs, the Freedom study, which is studying in-home frequent hemodialysis using a port, sort of the next stage device, they observed less restless legs, but in part kind of we pointed out in an editorial that that could be multifactorial, right? Because the person, place, and time of dialysis was changed.
Yeah,
So
yeah.
you had more, theoretically, people could have done their treatment earlier at a time where their restless legs is less. So I think that, the thought that we can influence sleep with dialysis, you know, to me was sort of proven with the overnight nocturnal dialysis studies, which really impacted the severity of obstructive sleep apnea. And then I do think that, if we, can have a moment to personalize the treatments that people are receiving, that would probably be very helpful. For instance, if people have insomnia, it may be that you can leverage the post dialysis tiredness and do them later in the day. If
Mhm.
they have restless legs, you may want to move them because the restless legs symptoms get worse in the evening. Maybe move them to earlier in the morning, right?
Yes.
So just kind of listening to the patient and working with them to find out like the best time for treatment, the best volume status for them, I think can be very helpful.
So we know this is a very common problem. We know it's a huge deal for people who have it. Now, do we have successful therapy? That's probably the final question that we need to answer to know if if it's worth our time to devote our time to this. So, do we have successful therapy for insomnia, restless leg syndrome, sleep apnea? For sleep apnea, it's more known, I guess, probably.
Yeah,
Also,
yeah,
restless leg syndrome has some pharmacological therapy. What do you
yeah.
do in these three cases, for example?
Yeah, I'd have to say that, my bias is whenever possible to use non-pharmacologic therapies. In both our CKD and ESRD patients, they're already on dozens of meds, right?
Yeah, yeah.
So in general, if you talk to patients, they would almost always prefer non-pharmacologic therapies. So, to kind of take them one at a time with insomnia, I think that working with your CKD and ESRD patients to sort out their sleep hygiene and optimize their sleep hygiene to limit the tobacco, alcohol, or drugs that may exacerbate insomnia makes a lot of sense. To refer them for cognitive behavioral therapy, CBTI, for insomnia is kind of what the general guidelines would say. I can speak to the kind of disappointing results we had in our sleep HD study that was just published in Annals, but nonetheless, that's what I still do.
Mhm.
And there are a number of medications that you can try that have rather modest effects long term on sleep on insomnia, such as benzodiazepines or zolpidem and that type of drugs, as well as melatonin. Melatonin itself seems attractive, yet in our in the dialysis population, at least, there was really no long-term effect to the use of 3 milligrams of melatonin a day. So for me, I favor the non-pharmacologic approach in the patient population that we see for insomnia. I can tell you, I was disappointed by the Sleep HD study results, which showed, no real impact of CBTI versus trazodone versus placebo over the course of 7 and 24 weeks. That study, which was kind of a randomized double-blind trial, kind of looking comparative effectiveness trial, looking at these different interventions, found that all three had a slight improvement from baseline to 7 weeks. The patient population that we were seeing, which included 126 maintenance hemodialysis patients, had a moderately severe insomnia, and they all kind of improved a touch. In our study, we found that there just was no observed difference between the two interventions and the placebo. I think you pointed out, when kind of reflecting on why we may have seen this, I think you pointed out that there may be a co-occurrence of multiple sleep disorders in the same person.
Yeah.
So we didn't stringently rule out people for sleep apnea, for insomnia or restless legs when we were studying insomnia. So it might be that the co-occurring sleep disorder sort of masked an effect of CBTI or trazodone. I think that one of the important observations that we made was that in the ESRD population, trazodone had a much higher rate of severe adverse events driven by cardiovascular events. Our study was small, and yet it does give you pause if that's a medication that doesn't seem to be overall remarkably effective, and it's associated with severe adverse events that maybe we should either do larger studies before promoting it or kind of set it aside.
But insomnia is the most difficult one, right? That's the one that we know the least about. I mean, the successful treatment eludes us still. But how about restless leg syndrome and sleep apnea? How about those?
Yeah, no, you're like, let's give people pills.
No, I'm not
No,
like it. I'm not like let's get people pills, but
no, I'm just teasing. I would
yeah,
say, for me, with restless legs, I really favor not using meds if possible, right? And so it's kind of working with the patient, to try and get an ideal time for their dialysis. Working with the patient to do more exercise because that's been shown to help. Patients that have restless legs while in treatment, they feel better if you're able to allow them to do the little bicycle or the cycling during dialysis. There's been a tiny study looking at cool dialysate as a way to improve it. When it comes to people with, severe restless legs that despite using sort of non-pharmacologic effects, it still impacts their lives. I would say that for both CKD and ESRD, there are a couple of medications that you can think about using and monitoring to kind of assess the risk-benefit ratio. So, gabapentin is a medication that is really widely used, at least in the US. So pregabalin and gabapentin have been shown to, in our populations, improve this sense of kind of mitigate the impact of restless legs and reduce symptoms. So that's one thing you can try. I mean, personally, I take great joy going through and discontinuing gabapentin in patients because I think it actually in our population tends to cause sedation and reduce cognition. But it has been shown to improve symptoms. Another, medications to consider are the dopaminergic medications, the sort of ropinirole, rotigotine, pramipexole. These medications, definitely impact and improve restless leg symptoms. However, all three also can cause an exacerbation of the symptoms through something called augmentation. So it's like you start them on a low dose or moderate dose, they get up to a moderate dose, and then they start having their symptoms earlier in the day and they're more severe. And so in many ways to avoid augmentation, I just really focus on the extent to which I can focus on the non-pharmacologic interventions. I think for me, one thing to think about is that you practice medicine as part of a team. And so in general, like I will try gabapentin. If it doesn't work, maybe try a low dose dopaminergic. If there is an improvement, I'll refer to a sleep physician, right? For
Yeah.
sleep apnea, it's kind of the same story, right? You're not alone in this. You work as part of a team. For sleep apnea, there's a couple things that are pretty exciting to think about. You can try to mitigate the severity of sleep apnea by making sure you have a handle on their volume status and they're not markedly volume overloaded in both patients with CKD and ESRD. For sleep apnea, if you send folks for a sleep study, either in-home or in center, you can assess the severity of their obstructive sleep apnea and central sleep apnea with an in-center study and treat them with CPAP. CPAP has been shown to kind of improve dramatically the symptoms if people use it. The uptake isn't 100%, so you still might be working to manage folks who have obstructive sleep apnea who refuse treatment. And so that's something to be aware of. I think among the general population and our CKD population, the tirzepatide is an GIP and GLP-1 drug that has a marked effect on weight loss. And the Pfizer just released this sort of headline that it also dramatically reduces sleep apnea. Those results haven't been published yet, but are on the horizon. So it may, at least in the US, be one of the first medications that you can prescribe for obstructive sleep apnea. It reduced the AHI by about 25. The thing that I didn't see in the sort of press release was like how much did it impact symptoms? And for our patient, like you pointed out, like a lot of times you're not treating the AHI, which is a number, you're trying to make them feel better.
Yeah.
And so for me, I think that would be something that's really important to see with this class of drugs. Do people have more energy? Are they less sleepy? Are they participating in daily activities?
Yeah, you want to make them feel better. That I like that. I like that quote. But you mentioned also sleep hygiene, which I think is actually, I agree with you, very, very important. Just things like stop drinking coffee. It
Yeah,
sounds
yeah,
obvious, but I had personal experience when I was, not sleeping enough, and then more and more coffee to wake up, and more
yeah,
coffee,
yeah,
and worse. And it's just like it's like a bomb.
yeah.
So,
Or
so
don't watch
especially
TV in your bedroom, right? There's a lot of things. Yeah.
exactly,
Stay
exactly.
off social media right before bed.
I'm sure that if you go off social media, it doesn't only help your sleep, I guess. Uh, so, how should we for like the final question on sleep disorders. How should we tackle this issue in our dialysis unit or transplant center? Let's say we're a dialysis physician or a transplant physician, particularly dialysis physician because it's so common in ESRD. Are there any good screening techniques or anything that you could do that would identify patients who have a severe problem easily with the least amount of time, let's say, because we're all, hard pressed with time?
I guess I can answer that in a couple different ways. I would say, just talk to your patient and find out what's bothering them. If you have them in the clinic with CKD or transplant, or if you are seeing them on dialysis for PD or HD, just say, like, how are you doing? What's bothering you? How can I help? And they may note that they have sleep problems, because that's one of the more common issues that people will endorse. I also think it's exciting that,
Sorry to interrupt you. They probably won't tell it by themselves, right? If you
yeah,
don't
yeah, yeah. So
specifically ask this, yeah, they might not report it, right?
they might not, but they may say that, they're having less energy, and then you can kind of probe a little bit more and see if it's sleepiness or fatigue, and then go from there. Like, they aren't going to say I have restless legs unless they've been
Exactly.
watching commercials a lot.
Mhm.
But they may say I have trouble falling to sleep. I have like this weird sensation when I lay down, and you can go from there.
Mm.
Um, and then I would say what I find kind of exciting is the focus on patient-reported outcomes, and kind of this systematic assessment of patient-reported symptoms, and the development of algorithms to kind of help us manage these things, since it's not necessarily what we're trained in. I think that you pointed out nephrology isn't necessarily particularly well trained in sleep and sleep disorders. To me, what's kind of fascinating is the number of hours spent in medical school on sleep in the US is one.
One.
On 1 hour. And it's something you do a third of your life, right? So
Yeah.
I think that there's an opportunity for all of us to kind of uh, uh, learn more about sleep. And then I think that, having tools that allow us to be systematic in the assessment, in addition to just kind of getting the patient's views on kind of what's really bothering them, is very helpful.
Okay. That's, yeah. The basics are important, right? I love that answer. So, we go now to the penultimate question, which is one geared towards our younger audience, our younger nephrology colleagues. So, if you had only one message to give a young up and coming nephrologist, what would that be? What would you say to yourself now after you've done uh,
Hmm.
whatever the time after the
Yeah,
time you've spent?
yeah. No, I would just say talk to your patients.
Yeah.
So for me, I think that, my interest in this was related to kind of findings in large clinical trials, but also in the talking to the patients I care for. And so, if you have time to spend with your patients and see how they're doing, and see how they're feeling, and see how they're doing with their daytime functioning and what's impacting that, you'll, really improve how they live their lives. And so for me, I think that, sleep is one thing that has a major impact on daytime functioning. And so I would just say talk to your patients.
That's great. I love that because medicine has become so algorithmical in a way, and
Yeah,
algorithms are helpful, but they may
yeah,
make you become a bit robotic in a way,
yeah, yeah, yeah,
and people really want to talk to a human.
yeah,
That's why I don't think a robot is gonna supplant us very quickly. So yeah, talk to people, right?
yeah, yeah. That'd be it.
Yeah. Okay, so to the last question, which is a bit of a getting to know you question, sometimes the toughest one for the guest. So, which book, two songs, and luxury item would you take to a desert island, Mark?
All right. So, so, so my book would be "The Stranger" by Camus. I think that was just really influential in my life, and it's a short book, so I'll have time to read it and reread it on the desert island. There's a quote in there that in English reads like, "None of the priest's certainties were worth a single strand of a woman's hair." And to
Yeah.
me, that is something that I recall, sort of the importance of being in the moment, kind of where you're at. Then two songs. In the U.S. I have sort of a U.S. focus. There's a rapper Eminem who has a song "8 Mile" that's a it really encourages you to do your best in a
Yeah.
way. And then the Lumineers are kind of a local indie rock band from Colorado that have a song "Hey Ho" that's fun. Then my luxury item, which is kind of a cheat, would be an iPad since I do a lot of my reading on the iPad.
Okay. Fair
So
enough.
I'm assuming there's Wi-Fi.
Yeah, yeah. Let's say there's Wi-Fi. Let's give you the Wi-Fi. Okay, Mark. I mean, this has been very illuminating, inspiring. So, talk to your patients. They have sleep issues, they have other issues. Maybe you don't need a drug for everything, and you'll be fine, right?
Yeah, I think you'll make people better. How about that?
Oh, that's great. That's great. Okay, ladies and gentlemen, thank you to listening to A Pinch of Salt. Stay tuned for other podcasts. Check them out. And, well, just thank you for everything.
Hey, thanks a lot. Have a great day or
Yeah.
great evening.
Right. Bye bye.
Thanks for having me.